60-year-old man comes to the physician for a health maintenance exam. He has a history of hypertension and hyperlipidemia, both well controlled with medication. He is up to date on vaccines. He previously smoked a pack of cigarettes daily from age 18 to 50. His last colonoscopy was at age 52. BMI is 24. BP is 130/80. What do you want to do for this fella? Choice A. Incorrect. Abdominal ultrasound is wrong. So, we do a one-time AAA ultrasound screen in males 65 to 75 for men who have ever smoked. Recognize that first, it's only males and not females. Second, it's a one-time screen for anyone who's ever smoked. Just once. Be mindful of how this criteria is different from lung cancer screening, which I'll get to in a moment. You are also likely to get a question on next step following a positive screen, so let's talk about that. If the aneurysm is 5.5 centimeters or greater, we do surgical repair. If it's under 5.5 centimeters, but it's grown 0.5 centimeters in the past 6 months, surgical repair is again correct. This is usually an endovascular repair with a stent. If the patient has, let's say, an aneurysm of 5 centimeters, then serial ultrasounds every 6 months is the correct answer. In this question, it's the wrong answer. The guy is 60 years old and too young. Choice B. Colonoscopy is the wrong answer. So, for the general population with no increased risk factors, colon cancer screening with colonoscopy every 10 years starting at 45 is the correct choice. Colon cancer is almost entirely preventable with colonoscopy when precancerous polyps are removed, and COMLEX wants this. Be skeptical when the fecal immunochemical test or FIT test is presented as a choice. It's not therapeutic and has a high false positive rate. Regardless, his last one was 8 years ago. If the question states that the patient has colon cancer in first-degree relative, you'll recommend screening 10 years before the diagnosis in that family member, or at age 40, whichever is earliest. For example, if patient's father was diagnosed at age 45, then we start at age 35 and repeat the colonoscopy every 5 years. Another high-yield scenario would be a patient who is at increased risk. If the patient has IBD, we start colonoscopies 8 years after the diagnosis in that patient, then every 3 years. The way they're going to assess that is that they're going to tell you a guy is 35. He was diagnosed with Crohn's disease in his 20s, and his dad is 54 and had colon cancer diagnosed 2 years ago. When do you do colonoscopy? Students will choose age 40. That's a distractor answer, and it's wrong. The answer is colonoscopy now, because he has Crohn's disease, and he should have been given a colonoscopy 8 years following his diagnosis in his 20s. Choice C is wrong. First, his BMI is normal. Diabetes screening starts at age 35 for overweight patients, which is a BMI over 25. It doesn't matter the screening method, A1C, fasting glucose, or glucose tolerance test. As an aside, we do lipid screening starting at age 35 in men, 45 in women in patients with increased cardiac risk factors, which is effectively every single patient in the United States. Prediabetics, family history, smokers, even physical inactivity qualifies as a risk factor. So, let's pretend they give you a patient that seems normal, and you're choosing between lipid screening versus A1C. The answer will be lipid screening. That's how they like to do things, guys. Realize there are a lot of vague criteria with increased cardiovascular risk that qualifies someone for a lipid panel, while weight is the principal criteria for diabetes screens. If their weight is normal, pick lipid screen over a 1C. Choice D. Low-dose CT, the chest. Correct answer. Requirements are patients who are 50 to 80 years, who have a 20-pack year smoking history, and currently smoke or have quit within the past 15 years. It's an annual screen until the 15-year anniversary of their quit date. Remember it like this. The low-dose CT screen has more criteria because it requires more frequent testing. The AAA screen doesn't have as rigorous of a criteria, but is a one-time test. Choice E. PSA wrong answer here, and probably wrong for all screening questions. The guidelines state that you should have a discussion starting at 55 for prostate cancer screening. It's pretty well established that PSA screening has an extremely high false positive rate, which results in unnecessary biopsies. That's a big deal, because the prostate biopsy carries complications like ED, incontinence, and increased patient anxiety. For every 1,000 men screened, only about 1 in those 1,000 avoids dying from prostate cancer. It's debatable that the harm of PSA screening outweighs the benefits.